We are live.
Okay. Sir, corner.
डॉक्टर विकास, आप वर्चुअल बैकग्राउंड मोड में आ जाओ.
जी सर. So it's another 1 minute and then we start.
डॉक्टर अजय, आपकी वॉइस ब्रेक हो रही है. डॉक्टर अजय,
एक्चुअली मैं थोड़ा होटल में हूँ ना, यहाँ सिग्नल थोड़ा सा कम है, मैं थोड़ा बाहर को आता.
डॉक्टर विकास, आप वर्चुअल बैकग्राउंड.
हेलो, is it audible now?
Better.
So good morning. Good morning, dear friends. Today we are again here with another session on management of ITP in children, which is quite common condition. We have Dr. Vikas Dua with us. He is the principal director of the Hematology, Oncology and BMT division at Fortis. We welcome him and I request him to please start the presentation.
Thank you, Ajay sir, for the kind introduction. I hope
Vikas, please start the presentation.
Sir, can you hear me and can you see the PPT?
Yeah, perfectly.
Yes, it's
good.
visible and you are audible.
Perfect, sir. Thank you, Dr. Ajay, Dr. Vipul, for the kind introduction. And friends, I welcome you all for the next session on the certificate course in hematology. And today we are going to discuss management of ITP in children. I'm pretty sure all of you as pediatricians do encounter patients who have bleeding issues. So whenever you have a patient who has come to your clinic with some ecchymotic spots, pedicle spots, epistaxis, hematuria, I'm pretty sure you must be thinking of doing a CBC and a coagulation before you make a plan. And when you do a CBC and you find that the patient has got low platelets, majority of time, the diagnosis which comes to our mind is immune thrombocytopenia. So friends, whether to treat that patient, to observe, what treatment to offer, when to offer is what we are going to discuss today in next 45 minutes. So friends, before we move on to the management, let's see what exactly ITP is. So ITP or immune thrombocytopenia is an immunological autoimmune disorder. It's an acquired autoimmune disorder characterized by low platelet count resulting from platelet destruction and impaired platelet production. So there was a time when we used to think that in ITP, there is just a destructive process which is happening. That means the platelets are being formed and when they enter into the circulation, there is some destruction going on. That means there are some antibodies which are eating up these platelets. But now the thought process has slightly changed in the sense that ITP was originally though thought entirely the result of platelet destruction by autoantibodies. However, now we know that the production of platelets in bone marrow is also suboptimal in patients of ITP, which means that the megakaryocytes can also be damaged by platelet autoantibodies, making them less productive. So we need to understand the fact it is not just the destruction which is happening in the blood, there is decreased production of the platelets because these antibodies are attacking the megakaryocytes also. So let's move on to a case. I think it's always good to discuss a case when we talk about the management. So let's look at this case, which is a classical case of ITP. You all must have seen this type of case in your busy clinical practice. A 3-year-old girl who has a history of bruising and pedicle spots for last 24 hours. The girl was absolutely all right, but the parents noticed that there are some bruises, some pedicle spots over the body. There is also a history of viral URI 4 weeks back. Otherwise, the girl is okay. There is no significant past history of bleeding or any family history of thrombocytopenia or bleeding. When you examine this girl, there were some pedicle spots, some ecchymotic patches which were present over the arms and legs. the girl was running, has come running to your clinic, is non-toxic, no joint bleeds, no hepatosplenomegaly, no lymphadenopathy, just ecchymotic patches and pedicle spots. And as we just discussed that you all will do a CBC, and some people might do a coagulation also. So when you do a CBC, in this CBC, the hemoglobin was okay, was let's say 13. The white cells were 6,000 with normal differentials, but the platelets were low. The platelet count was just 8,000. The peripheral smear was seen by a hematopathologist, and the peripheral smear was commented as there are few giant platelets which are seen, and otherwise there is no abnormality. So friends, this is a classical case of ITP, and ITP is always a diagnosis exclusion. Usually a patient of ITP will be presenting you to you like this only, looking well, clinically well, has come to your clinic, parents are worried, child looks well, and when you took the history, you may find a history of a viral process 2 to 4 weeks back. You may find a history of immunization 2 to 4 weeks back, but that is not the case every time. There might be no significant history of a viral process or a immunization. The child looks well. When you examine, you may find pedicle spots, ecchymotic patches, no organomegaly, no lymphadenopathy, otherwise well. And when you do a CBC, the other cell lines will look fine, just the platelets will be low. So friends, the key components in diagnosis is a detailed history and a physical examination and a review of the peripheral smear and a CBC by a good hematopathologist. So whenever we say ITP is a diagnosis exclusion, so we need to know what are the other causes of thrombocytopenia in children. So whenever you have a patient who's got low platelets, I always say that whenever I give a presentation on thrombocytopenia, I always say that either there is a production issue or there is a destructive process going on. So if there is a production issue, it might be an inherited disorder like a congenital amyloidocytic thrombocytopenia, TAR, thrombocytopenia absent radii, viscoid syndrome, dyskeratosis congenita, or some acquired problems in which there is a production problem like aplastic anemia, myelodysplastic syndrome, infiltrative disorders like ALL, AML means leukemias. Sometimes drugs, exposure to irradiation can cause decreased platelet production, and sometimes with nutritional deficiencies like folic acid or B12 deficiency, you can have decreased production. Then definitely, if you don't have an issue of the production, then there might be a destructive process going on. So destructive might not be always immune thrombocytopenia or idiopathic thrombocytopenia. Destructive might be a non-immune thrombocytopenia like in sepsis. Consumption due to infection, maybe a bacterial, viral, fungal infection. Microangiopathic disorders like TTP, HUS can lead to increased destruction. Bone marrow transplant related microangiopathy, like what we do in our day-to-day practice, transplant. Sometimes you have increased consumption, increased consumptive process, basically a transplant associated TTP happening in which your platelets are being eaten up, a mechanical heart valve, and a drug, you may be having a heparin-induced thrombocytopenia or an autoimmune disorder which causes destruction. And if that is also not the case, then a sequestration issue like a hypersplenism patient may have thrombocytopenia. So friends, please understand what is not typical of ITP. So if you have a patient who has come to your clinic with fever at the time of low platelets is not typical of ITP. You may have a history of fever 2 to 4 weeks back. You may be having a viral process 2 to 4 weeks back, but having fever at the time of presentation when the platelets are low is not typical of ITP. Bone and joint bleeds. If you have bone bleeds, joint bleeds, bone pains, joint pains, think of something else. Think of leukemia. If you have a bony, a patient who has got bony issues, bone pains, joint pains, think of an infiltrative disorder. If you have a patient who has got bone or joint bleeds, I would say think of a disorder like hemophilia rather than ITP. Lymphadenopathy, hepatosplenomegaly, usually you will not find in a classical or a typical case of ITP. Family history of low platelets. This is never found in a patient of ITP, because ITP, what we just discussed, is an acquired issue. Because of some reason, because probably an infection, viral process, immunization, or idiopathic, the platelets are low. So if you have a family history, think of inherited thrombophilias. Then abnormal low hemoglobin, abnormal hemoglobin levels. So what, please understand this point very clearly, that let's say you have a patient who has just got some pedicle spots, ecchymotic patches, and you see that in the CBC the hemoglobin is 7. It's a normocytic normochromic anemia. So that means a bicytopenia sort of thing can never be in ITP, but we will take this with a pinch of salt, because in a country like ours, many patients have nutritionally deficient hemoglobin, may have nutrition anemias. So it is always good to look at the indices. Like if I give you the same example again, what I was talking about, the 3-year-old girl has come to your clinic with 24 hours history of pedicle spots, ecchymotic patches, otherwise on examination, nothing, no hepatosplenomegaly. And if you see that the hemoglobin is 7 with a platelet count of 8,000, please look at the indices. If it's a, if the patient has a low MCV, that means it might be a iron deficiency anemia along with ITP. So the patient might be having IDA. So any patient, any nutritionally deficient patient can have ITP. So that then the diagnosis will change to IDA with ITP. But if you have a patient who's got low hemoglobin, but it's a normocytic normochromic thing, then it's something else, and not ITP. And similar logic will apply to WBC count and WBC morphology. So is there a need to do any diagnostic test other than CBC? So there are quite a number of people who ask me, Dr. Vikas, if I have a patient in which I have taken a good history, I've done the examination, and I don't have any other thought, I've done a CBC, a good hematopathologist has seen, and we are sure that this is ITP and nothing else, do we need to confirm it? Do we need to do any other test? The answer to that is no. So in young children with no past history, family history, examination features consistent with primary ITP, a complete blood count with differentials is sufficient to make a diagnosis, and then you can think, you can decide whether you need to give some therapy to that patient or not. Then this is a very common thing, a very common question which would be there in everybody's mind: is bone marrow examination necessary in every case of ITP? So friends, I just said, if you are sure, if you have taken a good history, if you have done a thorough examination, if your hematopathologist is sure that he or she is not missing anything, then bone marrow examination is not necessary in every ITP. Many people may say that when you are starting steroids, you can do a marrow. But if you ask me, if you look at the indication, I would say the recommendations by the American Society of Hematology, British Society of Hematology, nobody would say that you have to do a marrow. Even if you do a marrow in a case of ITP, what will you see? You will see abundant of megakaryocytes. A normal cellular marrow with abundant of megakaryocytes which will give you a sense of satisfaction that there are quite a number of platelets which have been formed and these are getting destroyed. Only when features are not typical of ITP, you may think of doing a marrow, and those cases are like a child who is less than 1 year of age. Less than 1 year of age, it's not very common to have ITP. I'm not saying we haven't seen ITPs in young children. We have seen quite a number of ITPs in children who are less than 1 year of age, but it's not very common thing. Anemia, what we have just discussed. If your hemoglobin is disproportionately low, then you may think of doing bone marrow. If other cell lines are affected, then you may think of doing a marrow. Very long-standing thrombocytopenia going on, you can do a marrow, or you have systemic signs and symptoms. Then you are justified in doing a marrow, but otherwise, in a typical case of ITP, bone marrow is not necessary. Before we talk about the management, we need to know how do we classify ITP. So ITP is classified in two ways. One is primary which is idiopathic, and the other one is secondary, in which you have a cause. So friends, majority of cases of ITP are primary, but very few cases can be because of a reason. A reason may be an autoimmune disorder like lupus, SLE, patient may be having APLA syndrome. A CVID patient may come to you with low platelets. A CLL patient, which is not common condition in pediatric age group, CLL is seen in older age patient. IVAN patients, autoimmune lymphoproliferative syndromes, ALPS patient, HIV patient, hepatitis C, B patients, post-vaccination, post-systemic infection. These patients can present to you with ITP, but that is secondary ITP and not primary. And the other way of classifying ITP is by duration. So if you have a patient in whom the duration is less than 3 months, let's say a patient has come to you on 20th August 2023, has presented to you on 2023, and the duration is less than 3 months. That means the symptoms started, let's say, 1 month back, 1.5 months back. Then you will say it is a newly diagnosed ITP. If the symptoms are been persisting between 3 months to 12 months, then you say it is persistent ITP. And if the ITP is lingering on, is been going on for more than a year, more than 12 months, then we will call it chronic ITP. So please remember this. Then let's come to management of newly diagnosed ITP. So friends, no active management is required in majority of cases. So majority of cases of newly diagnosed ITP don't require any therapy. We'll come to that. We'll discuss that in detail in subsequent presentation. But please remember this thing. Do not treat the platelet count. So this is a dictum. We are not chasing just the platelet count. We as clinicians, we as pediatricians, we as pediatric hematologists, we are treating the patient and not the platelet count, which is 5,000, 6,000, 8,000. Assess the severity and lifestyle before treating. So whenever we say that, let's say if you don't have a mucosal bleed, just you have skin bleeds, there is no need to treat, you can wait and watch. But that is not the blanket statement. That is not the case every time, because let's say you have a patient who is a 14-year-old boy who wants to play football. Then you cannot use that logic that we will not treat ITP, because if that patient gets hurt, he may bleed. So you may have to keep the platelet count more than 50,000, 100,000 in that case. Whenever you decide on the therapy, you should know the side effects of each and every medicine. We will discuss about that also. And please ensure that there is a good compliance and a good follow-up whenever you are keeping a patient on wait and watch policy. So if a patient is on wait and watch policy, please make sure that a good follow-up and compliance, if he's on any medicine, is being there. It is important to assess the severity, my friends, and it has been graded from 1 to 4. Grade 1 means patients who have minor pedicle spots, less than 100 pedicle spots or less than 5 small bruises, but no mucosal bleed. Grade 2 is a patient who has got more pedicle spots, let's say more than 100 pedicle spots, more than 5 large bruises, but still this patient doesn't have a mucosal bleed. Grade 3 is the patient who has got mucosal bleed, and grade 4, which has a patient who's got a bad mucosal bleed and you suspect internal bleed, that is grade 4. So please understand the fact that a patient who has got a mucosal bleed needs intervention, which simply means a patient coming to you with epistaxis, hematuria, GI bleed needs therapy, needs intervention, needs to be treated. And if that is not the case, please ask the patient to open the mouth. And if you see pedicle spots in the mouth, wet purpura, these patients also warrant therapy. For the other patients, which is grade 1, grade 2 skin bleeds, you can discuss in detail with the family, and you can always take a consent for observation, but that has to be decided on case-to-case basis. For example, a patient who, let's say, who stays near the hospital and understands that in case there would be a mucosal bleed, they will come to the hospital they understand the side effects of each and every medicine, and they give a consent for observation, you can do that. There might be a different case scenario. Patient living far off, patient living, maybe you are practicing in Delhi and the patient is from Jammu, is from far off, and doesn't have a good educational status, and you feel that they are not understanding the things well, and in case of bleeding happening and the platelets are low right now, 8,000, and they would not be immediately able to come to medical attention, then you can even start treatment for these type of patients. So whom to treat? Grade 3, grade 4, please treat. Children with no bleed or minor bleed, skin bleeds, may need or they don't need any treatment. Please look for medication side effects, quality of life, whether the patient is engaged in any type of contact sports. If the patient is being planned for anticipated surgery, then the thought process might change. Is there any platelet count for start of treatment? Quite a number of people who ask us this question, that is there any specific platelet count at which I should start the therapy? So the answer to that is yes. In adults, in 2018 recommendation from joint working group of several European hematology societies, Germany, Austria, Switzerland, were published, and they recommended corticosteroids for adults with ITP who have no or minor bleed and platelet count below 20 to 30,000 to be treated. Whereas observation can be done for people who have a more than 30,000 platelet count. But the similar joint working group recommended that low platelet count alone is not sufficient to start treatment in children with newly diagnosed ITP, and that majority of children with no or mild bleed do not require treatment. So please understand the fact, even the recommendations from Europe, from US, they don't say that you need to have a specific platelet count before you start therapy. You need to look for the evidence of mucosal bleed, and that's what each and every society says. Even American Society of Hematology published their guidelines in 2019, and if you look at this, in children with newly diagnosed ITP who have no or minor bleed, the ASH guideline panel suggests observation rather than steroids. So no steroids if somebody has got no or minor bleed. Look at the recommendation number 12. In children with newly diagnosed ITP who have no or minor bleed, the ASH guideline panel recommends observation rather than IVIG, and recommendation number 13 says observation rather than NTT. So all these medicines, which are the first line medicines in ITP, whether it is steroids, IVIG, and NTT, you should not use these medicines for somebody who has got minor bleeds or no bleeds. That means don't just look at the platelet count, look at the bleeding manifestations. We need to know the journal measures. In a case of ITP, avoid platelet function inhibiting drugs. A patient who has got ITP, you cannot recommend these patients tablets like brufen, mefrominic acid, because these medicines can have an effect on the platelet function. A patient who already has got a low platelet count and you recommend them these medicines, they can bleed. Similarly, avoid IM injections, because if you have a low platelet and you give IM injections, then you may have a hematoma formation. So the last point is activity of patients with platelet count more than 20,000 need not be overtly restricted. So it is not that a patient who's got, let's say, 35,000 platelet count, you will counsel the family that patient will not go to school, will stay at home. So parents need to be counseled. It is important to counsel, to have multiple sessions with the family, that they should not just see the platelet count, they should see the bleeding manifestation before they take a call. Then these are the first line of therapy. In case a patient has got mucosal bleed, these are the medicines which you can use: prednisolone, IVIG, NTT. Previously, we used to use a dose of 4 milligram per kg for 3 to 4 days, or 1 to 2 milligram per kg for 2 weeks. The response was seen in around 80% patients, and usually in 2 to 7 days, you see a response. But ASH has changed this, has changed the dosage schedule. I'll come to that. IVIG, a single dose is sufficient. 0.8 gram per kg. A single dose of 0.8 to 1 gram, I would say, per kg is sufficient. Previously, we used to say that 1 gram per kg for 2 consecutive days or 400 milligram per kg for 5 days. No, even a single dose is sufficient, and you see a response around 80% patients, and the response is usually fast. In 24 to 48 hours, the platelets rise. And similarly, NTD, which is difficult to arrange nowadays in India, the dosage is 50 to 75 microgram per kg, and that also works in around 50 to 70% patients, and roughly in 24 to 48 hours, you will see a response. Look at the wait and watch policy. So if you don't do anything, still 70 to 75% patients will recover on their own in 3 months. What does this mean? Let's say a patient has got low platelet count, has come to your clinic, and you are following, you're not giving any medicine, you're just observing. In 3 months' time, 70 to 75% patients will have a normal platelet count. That means the antibodies will disappear on their own and the platelets will rise. So the American Society of Hematology in 2019 has given specific recommendations for those patients who require therapy. So if you look at the recommendation number 14, in children with newly diagnosed ITP who have no life-threatening bleeding and or diminished quality of life, the ASH guideline panel recommends against course of steroids longer than 7 days, rather than course 7 days or shorter, which simply means ASH suggests that if a patient of ITP is being treated with steroids, then 2 milligram, 2 to 4 milligram per kg for a maximum of 5 to 7 days is sufficient. So previously, majority of the hematologists used to use 4 milligram per kg for 4 days or 1 to 2 milligram per kg for 2 weeks. But ASH clearly states in their recommendation that 2 milligram per kg with a maximum capping of 120 milligram. What does this simply mean? This simply means that let's say you have a 16-year-old boy whose weight is, let's say, 80 kgs. So that would not mean that you will give 160 milligram, 2 milligram per kg into 80, 160. You will still use a maximum of 120, and the duration would be for 5 to 7 days and not longer than that. When it comes to IVIG, we have already discussed 0.8 to 1 gram per kg single IV dose, slow infusion, let's say over 4 to 6 hours. And in around 80% patients, you will have a response. So people ask us, Dr. Vikas, if we have decided to treat, one thing is wait and watch, but if we have decided to treat, what will you recommend? I always say that if you want a very fast response, at NTD or IVIG is what we recommend, because steroids may take 2 to 7 days, but IVIG, NTD can show their response in 24 to 48 hours. But please remember one thing, friends, if a patient, let's say, cannot afford, there's a poor patient who cannot afford IVIG or have got other logistic issues, that doesn't mean that you will not offer steroids. You can still offer steroids to those patients who cannot afford IVIG or NTD, though the response may take some time. The platelets may rise after 2 to 7 days, but the beauty of steroids is that it increases the capillary resistance. If a patient is bleeding, you start steroids, the capillary resistance increase and the bleeding will stop, and which will give a sense of well-being in the family. The side effects of IVIG, we all know very well, because we all been using IVIG in our practice. Headache, sometimes anaphylaxis, fever, aseptic meningitis are known side effects of IVIG. A slide about NTD, though it's difficult to procure NTD in India, this used to come by the name of Winro previously. You need to have a hemoglobin of more than 10. The dosage is 50 to 70 microgram per kg, recommended only in Rh positive non-splenectomized patients, and the response is seen in 24 to 48 hours. We're not going to discuss in detail about this medicine because we don't have access to this now. Then how will you assess a response? How will you say that the patient has responded well? So if a patient is being started on one medicine and on two separate occasions, the platelet count is more than 100,000, is more than 1 lakh, then you say that there is a complete response. Then what is a partial response or just a response? If it has increased to more than 30,000 or doubling from baseline. So what does this mean? Let's go back to our own case. A child, 3.5-year-old girl, had a platelet count of 8,000. Let's say this girl has been started on IVIG. IVIG at a dose of 1 gram per kg was given to her. After 48 hours, the platelet count from 8,000 increased to 16,000. Then after a few days, it is 18,000. You will still call it as a response. It is not that every time you need to have a platelet count of more than 30,000. Even doubling from the baseline is a response. And in case these two criteria are not been met, then you will say that there is no response and you can think of changing the medicine if required for that patient. Now, if your patient is not responding to the first line medicine, so we discussed that let's say 70 to 80% patients responds to IVIG, steroids or anti-D. In case they don't respond and the patient has got mucosal bleed, warrants something else, then what is the second best line? So friends, there are no consensus on the second line treatment for patients of ITP or a newly diagnosed ITP, but these are the options. Options like rituximab at a dose of 375 milligram per meter square per week for 4 weeks. You see a response in around 3 weeks in around 70 to 80% patients. You can try high dose dexamethasone at a dose of 20 to 40 milligram per meter square per day for 4 days. And you see a response in around, I would say, a few days. And though the duration response is short lasting, but the response happens in around 80% patients. And as this is a high dose DEXA, there are quite a number of toxicities associated with it. Other medicines like Depson, Denazole, MMF have got their own side effects and they show a response in around 50 to 60% patients. Let's look at few slides on chronic ITP. What are the symptoms that predict chronic course? Age of presentation. Let's say somebody has presented to you at a very early age or in an adolescent age, then there are more chances of them to go into a chronic course. If the length of symptoms are been persistent for a longer time, more chances that these patients will have a chronic course. And studies have shown that females, there are more chances of having chronic ITP as compared to males. What are the differences between newly diagnosed and chronic ITP? So acute ITP is usually seen in children and chronic ITP is more common in young adults or adolescents. Chronic ITP more common in females, whereas there is no sex preference in newly diagnosed ITP. You may have a history of viral process in acute ITP, which may not be there in chronic ITP. Onset of bleeding is usually sudden in acute, insidious in chronic. Degree of thrombocytopenia is usually severe in acute, whereas it is moderate or mild in chronic. And majority of times it is self-limiting acute and chronic. If you end up in a chronic phase, if your ITP is going on for more than 1 year, then it may take a long time for your platelets to settle down to improve. What are the therapeutic goals? Therapeutic goals in chronic ITP. The goals is not to have a normal platelet count. Please remember, friends, in a case of chronic ITP, you are not looking at making a platelet count of more than 150,000. The goal is to minimize the risk of serious hemorrhage. That means a sufficient platelet count of less than 20-30,000 is good enough. This decrease restriction of activities so that the patient can be involved in the usual activities at least, and minimize exposure to toxic drugs. There are quite a number of drugs which are being approved to be used in chronic ITP. We should try to have a minimal exposure of these drugs to these patients. And for chronic ITP also, there is no consensus on treatment, but there are different options like dexamethasone, rituximab, drugs like immunosuppressive drugs like vincristine, vinblastine, these are all vinca alkaloids, azathioprine, MMF, cyclosporin. In adults, people do get their patients splenectomy done, whereas we don't encourage that. Then these are two newer medicines which have come in the market. One is an oral formulation, other one is an injection. The oral one is called eltromobag, which is a tablet, and romiplastin is an injection, which is given subcutaneously. And how these medicines work? These medicines, they are thrombopoietin analogs. They increase the production of platelets from the marrow. And the American Society of Hematology recommends that in children with ITP who have no life-threatening bleeding and who do not respond to first-line therapy, ASH guideline panel suggests the use of TPO agonist rather than rituximab. So ASH says that in case you want to use a second-line medicine, let's say it's a patient of newly diagnosed ITP who has been having frequent bleeding manifestations, frequent mucosal bleeds, and is not responding to prednisolone, methylprednisolone, IVIG, you don't have access to anti-D, then, and you have decided to use a second-line medicine. So ASH says that it is better to use a TPO agonist, either Rivulet, that's the trade name for eltromobag, or Romi, which is the trade name of romiplastin, rather than using the other medicines like rituximab. I tell you the problem with rituximab. Rituximab is a wonderful drug. Rituximab is a monoclonal antibody against CD20. So CD20 is a marker on B cells. B cells are the cells which produces the antibodies. And if you target the B cells, then the production of antibodies will decrease. But the flip of rituximab is that as you are going to target the B cells, you are going to attack the B cells, the production of antibodies will decrease, but it is going to make you immunodeficient. Your B cells will go down and you would be at risk of infection. So as says, avoid rituximab and use Rivulet or romiplastin. The dosage of eltromobag for pediatric patients who are more than 6 years is 50 milligram once in a day. For patients between 1 to 5 years, it's 25 milligram. And in our country, this medicine is easily available. There are certain things which you need to tell the family when you prescribe this medicine, that at least 2 hours before and 4 hours after the medicine, you should not give them something to eat. This should not be taken with milk, because milk would not allow this medicine to be absorbed, would chelate this medicine, and it is always good to take this medicine in the night. So let's say your child has dinner at around 8 o'clock in the night, give this medicine at 10, then don't give anything him to eat after that. Romiplastin, there is a starting schedule, 3 to 5 microgram per kg, weekly subcutaneous injection, and depending upon the platelet count, you decide whether to go up on the dose or decrease the dose, and the maximum is 10 mics per kg, which is the recommended dose for romiplastin. What is in general? What is in general the fate of patients who have got chronic ITP? Quite a number of people must be coming to you, do come to us, that my child has got chronic ITP. It's been going on for years. What is eventually going to happen? So 30 to 40% may go into spontaneous remission. So there are patients which go into remission each and every year. Some patients may continue to have mild thrombocytopenia. Only less than 10% goes into symptomatic severe thrombocytopenia. So please make the family ensure, please tell them, though maybe repeatedly, that majority of patients will improve on their own. And if a patient doesn't respond to anything, even all the medicines are being exhausted, a patient is being offered a spinectomy, which is not a usual thing in pediatric age group, that is refractory, that is the definition of refractory thrombocytopenia. Just the last slide, any role of spinectomy in children. So we all are against spinectomy. We don't encourage or suggest spinectomy for a patient, a child with ITP. So that's what ASH also states, that in case you are pushed against a wall, then still you can try rituximab rather than doing a splenectomy. So splenectomy is a big no. So with that, I thank you all for a patient hearing, and I would be more than happy to take any questions which you have. Thank you very much.
Great, Dr. Vikas. Now we have few questions in the question answer session. Question answer section. The first is by Dr. Amit Gupta. What is the maximum dose of IVIG?
Sir, I've just said that the dose what has been recommended is 0.8 to 1 gram per kg. So let's say you have a patient who is 60 kgs. There is no capping. You will use 60 grams. So there is no maximum. You have to use 0.8 to 1 gram per kg of IVIG for a patient who has ITP, and you have decided to use this medicine.
Is the NTD same as used by gynecologists?
No, that's a different medicine, sir. So the trade name for NTD, what we use for ITP is Vinro. Somehow Vinro is been withdrawn from Indian market and it is not available. So the IM injection which the gynecologists use is not the same what we use for pediatric ITP.
When to check for response on 2 occasions after treatment?
Ideally after a week. So let's say if you give a patient, let's say IVIG, and after 48 hours the platelet count has increased, then the second response ideally should be checked after 7 days, and then you say whether it is a complete response or just a response.
ITP mother gives birth to a child. What are the guidelines?
So guidelines are plain and simple. If a patient has got neonatal, so there are 2 types of neonatal thrombocytopenias. One is neonatal autoimmune and the other one is neonatal alloimmunes. So what we are talking about here, what Dr. Smita is trying to ask is about neonatal autoimmune thrombocytopenia. So the mother has got ITP or an autoimmune disorder and has delivered a baby. So then you can use IVIG at a dose of 0.8 to 1 gram. Please don't use steroids. Steroids are contraindicated in neonates.
Dr. Asim, you want to ask something? Dr. Asim Gupta? Unmute yourself and ask. Yeah, please. Dr. Asim, you are live now. You can ask.
Hello.
Anji, we can hear you. Please ask your question.
Sir, you said that we have to check on 2 separate accounts, the platelet counts, and it has to be more than 1 lakh. So when it will be after giving the dose of NTD, how many hours exactly after the first test and how many?
So NTD, Dr. Asim, I said that NTD is not available nowadays, but in case you have used NTD at a dose of 50 to 75 microgram per kg, then in 24 to 48 hours, you will have a response in 50 to 70% patients. So that is the first time point, 24 to 48 hours, when you can check the platelet count, and if it has increased, then you can recheck after 7 days. And if on 2 separate occasions, I'll give you an example. Let's say a patient has got a platelet count of 8,000. You give NTD, after 48 hours, the platelet count is 18,000. It has increased. That means there is some response which has happened from 8 to 18. And then after 1 week, let's say the platelet count is 22,000. Then you will say that on 2 separate occasions, 7 days apart, there is a response. It is not a complete response, but it is a response. In case your after 48 hours of starting IVIG or NTD, from 8,000, the platelets are let's say 10,000, and it has remained like 10,000, and the patient continues to have a mucosal bleed, then you can think of adding an alternate medicine to that.
Sir, in the same example, if we have checked the platelet count and it is not up to the response mark, then will we term it as a failure?
Yes, that's right. That means no response. You call it no response.
That will be same platelet count, or if it has marginally increased, say 8,000, it has increased to 12,000, then we are in a dilemma, or we will say, okay,
no, that's no response. You should have at least a doubling from the baseline. at least a doubling. So if from 8, it should be at least more than 16.
Thank you so much, sir. Thank you.
Role of HSCT.
Oh, so there is no role, though in some books you may find a role of hematopoietic stem cell transplant, but we as transplant physician, we don't find any role of hematopoietic stem cell transplant in ITP.
Prednisone should be given for how long?
So the ASH societies, the American Society of Hematology Society, recommend to be given for 5 to 7 days at 2 milligram per kg.
So if there is only partial response after IVIG in severe ITP, should we repeat the dose?
So that's a very good question. So let's say you have given IVIG to a patient, there's a response, not a complete response. Response has happened. Usually IVIG response is short lasting for 2 to 4 weeks. If the response has vanished and the patient has again got a mucosal bleed, you can always think of repeating a dose of IVIG, the same dose, 1 gram per kg.
How to approach siblings with SJIA and chronic ITP?
So you're talking, I think Dr. Vikas is talking about systemic JIA. So systemic JIA and chronic ITP, you have to treat, if you have a patient scenario like this, you have to treat JIA, you have to treat an autoimmune problem, I would say. Whatever autoimmune problem the patient has, you have to treat that, and the ITP the platelets will improve.
Role of Dapsone?
So Dapsone is a fantastic drug. We have used Dapsone in quite a number of our patients at a dose of 1 to 2 milligram per kg. It's available in 50 and 100 milligram tablets. It comes in a bottle. So it works in 50 to 60% patients. But the only problem with Dapsone is that it can cause methemoglobinemia. So few of our patients we have seen the saturations going around 88-90% on a routine follow-up. When you do a VBG, you find high methemoglobin levels. So there was a time when we used to use Dapsone for quite a number of our chronic ITP patients. But from the time these two new medicines, Eltromobag and Romiplastin, are there in the market, we have stopped using Dapsone. But yes, it works well.
If you want to give IM vaccination to a child with ITP, what platelet levels are safe and what needs to be done if they are below safe levels?
So ideally, you should have a platelet count of more than 50,000. Otherwise, there would be a hematoma formation. So if you want to bring it to a safe level, then you give a short dose of steroid or IVIG to that patient before you give the IM injection.
Any role of giving platelet in such cases?
No. So there is no role of giving platelet transfusion to a patient of ITP, because if you give platelets, these platelets will also get destroyed by the antibodies. There are specific indications, very few indications of transfusing platelets for a patient of ITP. Let's say a patient has got IC bleed. So you have started IVIG and methylprednisolone both to that patient. Though these medicines may take its own sweet time, so will take 24 to 48 hours to act. So whatever little benefit transfusing platelets can give, so you should transfuse. Similarly, in a scenario like hematuria, if you have a patient who has come to your clinic with hematuria, the studies have shown that there is a 30% chance that these patients may have IC bleed. I don't know what is the logic behind that, but studies have shown patients who have got hematuria, there's a 30% chance of having an IC bleed. So you recommend or you transfuse platelets to these patients. Otherwise, no need.
Although you have answered, I think the repeat answer is needed. When do you check response after oral steroids?
So, sir, when you give steroids, let's say you give steroids at a dose of 2 milligram per kg, the capping dose is 120 milligram. In 2 to 7 days, you have a response. So not each and every patient will have a response in 2 days. They may have a response after 7 days. So what we do in our practice, after 3rd day, we check the response.
And an ITP patient for surgery, what are the safe levels?
So it depends. It depends whether it's a minor surgery, major surgery, which organ surgery is to be done. In neurosurgery, you may have to keep a platelet count of more than 100,000. It depends what type of surgery is being advised. In minor surgeries, even a 30,000 platelet count is okay. For major surgeries, 50 to 100,000 platelet count.
How long can we give romiplastin?
Oh, we've been using romiplastin for years. So 1 to 2 years, you continue romiplastin. The only problem with romiplastin theoretically is the risk of fibrosis. So you continue for 1 to 2 years, and then you try to taper 1 microgram per kg every year if the patient doesn't have any bleeding manifestations or doesn't have a significant drop in the platelet count.
Is NTD available in India?
No, so the IV formulation is not available.
When you give oral steroids, how do you taper them after pulse therapy?
So pulse, the thing is same, sir. In case you have a patient of IC bleed or a significant GI bleed, and you want to bring the platelet count up, and you have given steroids, IVIG both, and you have decided to give a pulse of 10 to 20 milligram per kg of methylprednisolone, then after 3 days of pulse, you give a short course, around 7-day course of prednisolone, and then you start decreasing.
Indications for SDP, RDP. I don't know what is SDP, RDP.
SDP is single donor platelet, and RDP is random donor platelet, sir. So we already discussed the indications of transfusing platelets in ITP.
8-year-old girl with persistently low platelet count of around 20,000 for more than a year, minor bruises. What can be done? Patient receives steroids on off prescribed by various doctors.
So that's what Dr. Namrita, we have discussed, that in a patient of chronic ITP, is it chronic or acute? So I think
persistent for 1 year likha hai.
हाँ, 1 साल है तो एक chronic हो गया, sir. So 8-year-old girl, chronic ITP, 20,000 platelets, some minor bruises. So no consensus what to do in a patient of chronic ITP. You have to treat the patient and not the platelet count is the dictum. So we will not do anything.
Side effects of Dapsone.
Dapsone, sir, we have methemoglobinemia. We have talked about that.
Can we use prednisolone with 4 milligram per kg also?
So previously we used to do that, sir. A short course of 4 milligram per kg for 4 days is what we used to do. IAP also used to recommend that, but latest recommendations have changed, and 2 milligram per kg is equally good.
Role of repeat BMA in ITP, chronic ITP.
No. So we need to understand the fact that those patients who land up in chronic ITP, there might be a secondary cause. Secondary cause can be APLA syndrome, can be a common variable immunodeficiency, chronic hepatitis B, CHIV, H. pylori. So there is no role of repeating a marrow. You will not find anything in marrow. Just what you need to understand is that you should not be missing MDS, myelodysplastic syndrome, at the first time. So when you do a marrow, you have any doubt, please take an extra sample for cytogenetics.
Role of bone marrow aspiration in refractory cases after giving steroids.
So in a patient, so what we say that if a patient has been having a long-standing ITP, a chronic ITP, then yes, you should do a marrow before you proceed further.
Can you repeat the dose of Dapsone, dose and duration?
Sir, 1 to 2 milligram per kg, 1 to 2 milligram per kg, and usually in 2 to 3 months you will have a response, and then depending upon the response, you decide for how long you want to continue that.
4-year-old with chronic ITP responded to romiplastin on tapering. The patient had a fall in platelet once the romiplastin was skipped for a week. What is the regime of tapering romiplastin?
Sir, I think that's beyond the scope of today's presentation, but I can tell you that if you have a patient who has got ITP and you have started him or her on romiplastin, the starting dose is 3 to 5 mics per kg, and depending upon the platelet count, you increase by 1 mic per kg or you decrease by one mic per kg. The dose, it all depends on the response and the platelet count. So I don't have the exact number right now, because we also see the recommendations each and every time we do that.
Does the Dapsone causes bone marrow failure also? Chronic use?
Bone marrow failure, I am not very sure. I don't think so, but I am not very sure about this.
How long it takes to get the response of?
Okay, so what Dr. Jolly wants to ask is how long it takes to have a response after eltrombag or romiplastin. So Dr. Jolly, usually after 2 weeks of eltrombag and after 2 to 3 injections of romiplastin, weekly injections of romiplastin, we see a response.
Dr. Tanushri, can you please send the recommendation on romiplastin therapy?
I just said that you have to look at the literature, and because it's not something which I can tell you just right now. So there are specific recommendations depending on the platelet count, how to increase and decrease the dosage.
As a physician, we're told we should not be writing to patients of ITP in prescription for routine things.
So sir, मैंने बोला आपको paracetamol के अलावा you have to avoid other NSAIDs. So please don't write other NSAIDs in case a patient has got pain or fever, and the other medicines like heparin, other things should not be used.
ATG or romiplastin, which is better?
So ATG we don't use. ATG is for aplastic anemia.
Okay, so that was quite a run. Thank you, Dr. Vikas. Dr. Jagdish, comments and questions and something?
Yeah, I think a very elaborate presentation, Dr. Vikas, very nicely covered all the aspects which are common and which are controversial, and highlighted how to address the issues. And of course, the question answer itself showed that a lot of interest was generated, and all the answers, all the questions have been answered by Dr. Vikas. Just a couple of things. This one is regarding the bone marrow examination in ITP. Very rightly said that if there are the clinical features are consistent with ITP, that is the absence of other features, plus the CBC does not show anything other than, say, a low platelet, there is no need to do. But this appears to be very simple statement, but it may be a little difficult to follow in situations where, like, say, I worked for almost 3 decades in Kalavati Hospital, where most of the patients, they already have some anemia. Now, looking at anemia, 60 to 70% population has anemia in our country, and some cases do come with leukocytosis and other things. So it's individual decision to be taken whether a marrow is required or not. And those cases who are educated, who can come to follow up and say they would comply with whatever advice has been given. Again, regarding the treatment policy, say observation approach is best suited for those. But again, social factors were highlighted by Dr. Vikas as well. There are some social factors like living far off and cannot reach. And I mean, in Kalavati, we had seen that if there is some problem, the patient has some 2 to 3 hours time he spends before he can get a nasal packing done for epistaxis. And then the fellow will tell, "Tumhara to Kalavati mein ilaaj chal raha hai na, wahin jaake karwao." So they will not touch the patients. So these things had to percolate down, and the management has to be taken in light of these things as well. So, and I think newer drugs, what Dr. Vikas described, he might be having a lot of experience with eltomopag and romiplastin. But one thing the listeners should know, that these are not the drugs for acute ITP in any way. Whatever severity, wherever you are needing drugs for acute ITP, these are the drugs for chronic ITP, because he very rightly emphasized that the response comes in 2 to 3 weeks time. So I think that's all I have to say. And for the secondary cases, I think looking at the hepatitis B, C, and HIV, if you have not done HIV earlier, one should look at these and try to rule out chronic variable immunodeficiency, particularly in refractory cases. So that's all from my side. Thank you.
Thank you, sir. Thank you. Because there is another question. If you have sent the patient home, how frequently he should come with a platelet count to you or to his physician? He's doing normal. There is no issue with him, but how frequently he should be going to get his platelet done?
So we go by the symptoms, sir. If the patient is clinically well, no evidence of bleeding, we don't have to check the platelet count.
Okay, great. That's very simple. Thank you. Thank you, Dr. Vikas, for sparing time and joining us in this 14th session of hematology course. We are just 2 sessions away in completing this course, and I request everyone who has joined us today to reach the venue on 3rd of September from 9 a.m. to 3 p.m. We all will be joining. There will be a convocation, and there will be 5 sessions covering almost all the topics, having panel discussion. The venue is CNBC, Chacha Nehru Bal Chikitsalaya in Geeta Colony, New Delhi. Address, location has been sent on WhatsApp to all the participants. Any query regarding it, office can be contacted about. Everyone is requested to join us on 3rd of September. Thank you very much, Dr. Vikas. It was
Thank you,
great
sir.
pleasure having a session with you. Thank you.
Thank
Pleasure
you.
is all mine, sir. Thank you very much.
Thank you,
Dr.
Vikas. Thank you, Dr. Vipul. Thanks.
Thank you, sir. Goodbye.